This is Chapter 230, entitled Management and Prevention of Shunt Infections by Vijay Ravindra and J. Reva Cambrin. The key concepts for this chapter are as follows. Cerebrospinal fluid shunt infection is a common problem with an incidence ranging from 4 to 20% per patient and 2 to 12% per procedure. It can lead to significant patient morbidity and cost or stress on the healthcare system. Staphylococcus species and gram-negative bacilli are the most common pathogens, and they usually present within 30 days of shunt surgery, but can occasionally occur up to 1 year after insertion. Preventative measures, such as the implementation of evidence-based surgical checklists and protocols, can drastically lower infection rates, with a relative risk reduction of 36 to 66% and an absolute risk reduction of 2%. In addition, improved techniques in sterility, preoperative antibiotics, and surgical technique also can reduce the overall shunt infection rate. The treatment for suspected cerebrospinal fluid shunt infection includes sampling of cerebrospinal fluid with complete removal of retained hardware or implants when possible, followed by intravenous antibiotics for 7 to 21 days, and subsequent shunt reimplantation. The optimal length of antibiotic therapy remains to be determined. A recent randomized controlled study found the use of antibiotic-impregnated catheters as an effective way to reduce the incidence of shunt infection in children and may be cost-effective when compared to standard catheters. Epidemiology. Hydrocephalus is a common neurological condition, and it accounts for nearly 0.6% of all pediatric hospital admissions. This accounts for nearly 38,000 hospital admissions, which equates to 430,000 hospital days, and nearly $1.5 to $2 billion in expense yearly. Hydrocephalus is a chronic disease with increasing prevalence, but decreasing mortality and increasing morbidity. This is likely secondary to improved survival of premature infants. Cerebrospinal fluid shunt placement is the most common treatment for hydrocephalus. There's increased use of shunting as treatment with a corresponding increased complication profile, which can include shunt failure and shunt infection. 40% of shunts will be revised within 2 years of placement. Infections are common complications of CSF shunt placement, and the incidence can range from 2 to 12%. Features of shunt infections. Rates of shunt infection have varied throughout the literature. In 1996, a study of 884 patients demonstrated an infection rate in the postoperative period within 1 month of 6.2%, with a subsequent infection rate of 7.4%. Drake found a similar infection rate of 8.1% in a population of 344 patients with a new CSF shunt. The Hydrocephalus Clinical Research Network, or HCRN, reviewed 7,071 children who underwent uncomplicated CSF shunt placement from 2001 to 2005. At 2-year follow-up, there's 825 infections and subsequently 4,434 subsequent shunt procedures. The authors found an infection rate of 11.7% per patient and 7.2% per procedure. The cumulative incidence per hospital ranged from 4.1% to 20.5% per patient and 2.5 to 12.3% per procedure. This variability was accounted for by individual patient, hospital, and surgeon factors. In 2014, Simon also reported a first-time infection rate of 11%, having identified 112 children out of 1,036 undergoing initial shunt placement. The work of the HCRN has demonstrated that preventative measures can drastically lower numbers, but a reasonable estimate of shunt infection among patients is approximately 4 to 8%. In addition, preventable shunt revisions can occur in 44% of cases, with one of the most common etiologies of recent shunt infection as a predictor of preventable shunt revision. Timing of shunt infections. Most shunt infections occur within the first 3 months after initial placement or shunt revision. Casey described over 90% of shunt infections occur within the first 90 days of initial shunt placement. Simon demonstrated that 91% of shunt infections, or 102 out of 112 children who developed infections, occurred within the first 12 months of the initial procedure. They also looked at reinfection rates of 118 children and found a median reinfection period of 66 days in 31 children, establishing a 26% reinfection rate after the first CSF shunt infection. Although it is most common for CSF shunt infections to occur early after shunt placement, and surgeons dispute the notion of a delayed shunt infection, some studies have shown that shunt infections 2 to 3 years after initial shunt placement can occur. Delayed infection may present with less virulent organisms, and although these cases are rare, they should be considered. There are several risk factors to be considered when discussing the topic of shunt infection. Most notably is age. This is the leading risk factor for shunt infection. Neonates and very young children are at the highest risk for CSF shunt infection, with a 17 to 20% first-time shunt infection rate. There is a mean 4 to 8% infection rate for all shunts placed. Age-related changes in the density and identity of bacterial populations likely play a large role. In addition, neonates have a deficient immune system, which may make them more susceptible. Neonates may also harbor a more highly adherent strain of coagulase-negative Staphylococcus, which is the most prevalent organism leading to shunt infections. An additional risk factor is a previous shunt revision. Simon reviewed 579 children and found a higher incidence of infection after multiple revisions versus initial placement. Another prospective study of 1,036 children who underwent initial shunt placement, 102 developed infection within 12 months of placement, and 32% of infections occurred after 1 or more revisions. Children with a single revision had a 3 times higher odds of shunt infection compared to those without a revision, and those who underwent 2 or more revisions had a 13-time odds of infection. Reinfection rate in a retrospective review of 675 children with initial CSF infection demonstrated a 6-month rate of 14.8%. Children with reinfection had less time between shunt placement and initial infection, and non-surgical treatment, i.e. antibiotics only, was associated with an increased reinfection compared with surgical treatment. The presence of a gastrostomy tube has been controversially discussed in the setting of shunt infections. The UPS infections are not common after clean elective abdominal procedures. However, infections may occur after emergency abdominal surgery when there is intra-abdominal contamination. Rader et al. Revealed a 71% shunt infection rate after PEG tube placement versus 29% for surgically placed gastrostomy tubes. Gassis et al. Demonstrated a 23.5% infection rate after shunt after G-tube placement for children with brain tumors and CSF shunts. In 2014, Simon demonstrated that the presence of a gastrostomy tube at initial placement of a shunt carried a hazards ratio of 2.0 for infection. If a gastrostomy tube must be placed before or after VPS, then a surgical placement rather than percutaneous placement should be used. Hydrocephalus etiology is another potential risk factor that has been studied. However, there is no clear evidence for increased infection rates among specific etiologies of hydrocephalus. In a large study, it was found that myelomeningocele and post-hemorrhagic hydrocephalus etiologies were not significantly correlated with infection after initial shunt insertion, but were very strongly correlated with the patient's lifetime risk of shunt infection, which may more reflect a lifetime dependence and shunt necessity. Surgical factors that have been studied, including the use of prophylactic antibiotics, antibiotic impregnated catheters, site prepping, including hair clipping, type of skin cleanser, double gloving, and prophylactic intraventricular antibiotics have been found in multiple reports to be beneficial in lowering shunt infection rates. Sources of shunt infection include colonization at the time of surgery, wound breakdown over the hardware, hematogenous spread from another source, or retrograde extension from a perforated viscus or peritoneal infection. Most infections can occur 60 to 90 days from surgery. Postoperative CSF leak is a risk for infection given the direct pathway to hardware and seeding. Signs and symptoms of shunt infection may vary based on age, virulence of the pathogen, and location of infection. Very young children may present with fever, vomiting, irritability, and in severe cases, apnea or bradycardia. Older children may present with fevers, headaches, nausea, vomiting, pain, and possibly gait disturbances. It should be noted that children of all ages may present with seizures, either as recurrent seizures or new onset seizures. Visual changes may appear, but this is typical in older patients. It's often that low virulence organisms are the cause of multiple successive shunt malfunctions. Infection of the ventricle and shunt hardware may present as a more severe illness or meningitis, including fevers, nuchal rigidity, and altered mental status, and peritoneal infections may have localized abdominal pain, shunt malfunction, and potentially an abdominal pseudocyst. Common skin pathogens, i.e. Staphylococcus epidermidis and others, can cause slow, indolent shunt infection and malfunction. Staphylococcus aureus may cause a more aggressive infection that is accompanied by erythema and pain along the shunt hardware. Acute presentation of a severe abdominal pain or septicemia may be seen with more virulent organisms, including E. coli. Bacteremia and shunt nephritis are established complications seen in patients with ventriculoatrial shunts. Diagnostic testing in the diagnosis of shunt infection can be quite helpful. Although traditional imaging may help with diagnosing shunt malfunction, it's often not conclusive in infection. Plain radiographs may reveal free abdominal air, which can suggest potential ruptured viscus and shunt infection. Complex shunt infections in the setting of complex ventricular morphology may demonstrate contrast enhancement on MRI imaging or CT with contrast imaging. Peritoneal imaging, either CT or ultrasound, may be used to diagnose abdominal pseudocyst formation. Laboratory evaluation is the mainstay of diagnosis. CSF analysis is usually obtained by percutaneous withdrawal of fluid from a shunt reservoir. Contney demonstrated that a causative agent could be isolated from a percutaneous tap of a shunt reservoir in nearly 86% of patients with a shunt infection. Some organisms may grow in a delayed fashion, thus CSF specimens should be held for a total of 10 days. Although there is a theoretical risk of introducing infection, the actual risk of infection with a shunt tap is very low. Less than 1%, or 1 out of 542 taps in a study, were suspected to develop a post-tap infection. CSF should be evaluated for cell count, protein, glucose, as well as gram stain and culture. CSF cell counts may be elevated for weeks after a shunt infection. Recent intraventricular hemorrhage or craniotomy may also cause an abnormal profile of cerebrospinal fluid. CRP levels can be elevated in patients with shunt infection, but can also represent inflammation or infection and thus should be interpreted carefully. Causative agents for shunt infections include the Staphylococcus species, which are the predominant isolates from most studies. Coagulase-negative staphylococci, or Staph epidermidis, account for nearly 75% of infections. Staphylococcus aureus is the second most common infection. The Staphylococcus species can create a biofilm on shunt hardware that is able to evade the immune system. Gram-negative bacteria are the next most commonly isolated group of pathogens. Other skin colonizing bacteria such as diphtheroids, Cutibacterium or Propionibacterium, and anaerobic bacteria are more variable. Cutibacterium can serve as an indolent infective agent that may cause repeated shunt infections. However, they may take greater than 1 week to isolate. Thus, in long-standing symptoms, a high index of suspicion should be obtained. Polymicrobial infections may occur, and in the presence of this, a prompt enteric etiology source investigation should be launched. Antibiotic-impregnated catheters alter the profile of pathogens and may promote a bias towards gram-negative bacilli. With respect to treatment and surgical intervention, there are 3 mainstays that are typically described. Number 1 is medical management with antibiotics. This management strategy is fraught with significant failure rate and a longer length of stay with a mean hospital stay of 45 days compared with surgically treated groups. The second treatment method includes distal shunt catheter externalization or removal of infected shunt with immediate replacement with a new shunt with antibiotic treatment. This carries a 90% cure rate with a mean hospital stay of 33 days. The third treatment strategy, which is the most common and most favored, is removal of all shunt hardware, placement of an external ventricular drain or ventriculostomy, with antibiotics followed by new shunt placement. This is afforded with a 100% cure rate and a mean hospital stay of 25 days. Treatment with antibiotics is dictated by the isolated pathogen. Empiric treatment should have bactericidal activity against the most common pathogens, including Staph epidermidis and Staph aureus, and have penetration to the central nervous system. The use of vancomycin has become first line due to rising rates of methicillin-resistant Staph epidermidis and Staph aureus. Empiric therapy should also cover Pseudomonas, which is a gram-negative bacilli. Empiric antimicrobial treatment can be tailored once specific organisms are isolated and drug sensitivities are performed. The duration of antibiotic treatment is quite variable. The recommended interval between shunt externalization and reinsertion of a new sterile shunt ranges from 10 to 14 days, but can vary significantly in the literature. Culture should be negative for 48 hours before reinsertion of a new shunt. The Infectious Disease Society of America, or IDSA guidelines, last published in 2017, can help guide neurosurgeons in choice of drug and length of treatment. With regards to outcomes of infection and treatment, Hunt and Holmes demonstrated that cognitive outcomes in children with myelomeningocele were lower in those who had experienced shunt infections versus those who did not. Shunt infection, if not treated properly, may lead to the development of loculated complex hydrocephalus. Walters demonstrated a 34% mortality in patients with hydrocephalus and shunt infection versus 18% in patients with shunts without infection. Kessel in 2006 demonstrated a reinfection rate of 26% in 70 children treated for shunt infection. Similar rates were reported by Simon in 2014. Total removal of hardware is associated with a lower hazard ratio of reinfection, but this finding is not statistically significant. Rifampin has been demonstrated to afford a decreased infection risk. There is insufficient evidence, level 3, to recommend the use of intrathecal and systemic antibiotics for patients with CSF shunt infection in patients where hardware cannot be removed. Thus, it is recommended when able, all hardware be removed. Preventative measures for shunt infections are a very interesting topic of study. Published standardized protocols targeting hand washing, preoperative preparation of the patient's head, double gloving, and minimal handling of the shunt reduce infection rates. The Hydrocephalus Clinical Research Network has demonstrated that a 36% relative risk reduction in shunt infection rates through the use of a standardized 11-step shunt insertion protocol. Outside of any protocol, limiting the number of people in the operating room, using a dedicated scrub team, and shortened duration of surgery are all factors that reduce infection risk. The use of antibiotic catheters were introduced in 2003, and these catheters are typically impregnated with either rifampin, clindamycin, or minocycline, and they release antibiotics for approximately 50 days. An HCRN study demonstrated similar rates of infection in patients who utilized antibiotic catheters versus those that did not. However, BASICS, which is a randomized control study, demonstrated a decreased shunt infection rate from 6% to 2% compared to standard shunts, with an overall improvement in cost effectiveness. Thus, this may represent a future avenue to further prevent and reduce shunt infection rates.